Using the suction device, you want to place the patient on the lateral recovery position. You want to then test the suction device by turning it on. You want to then occlude the pipe and ensuring that it gets up to 350 milliliters of mercury. If it does not, test for any leakages or any problems with the machine. You want to then test suction by occluding the end of the airway like so. Then insert the rigid catheter into the mouth only as far as it can be seen. Use suction in a circular motion only on the way out. Suction time should be less than 10 seconds. 5 complications that can arise from using a suction device is induced vomiting, induction of bradycardia, hypoxia, aspiration, and soft tissue trauma. And it is very important not to use a rigid catheter in a moving vehicle. With the bag valve mask, you want to look for any leaks. So to do this, you need to try and inflate the bag while sealing it off. This will show any leaks present. You then want to also fill up the reservoir to make sure that it also doesn't have any leaks. So you want to then assemble the bag. So to do this, the reservoir and also the mask, like so. And you also then want to attach the bag valve mask to running oxygen. So you'd want this to be running at a minimum of 10 litres per minute. So you want, and then whilst that's occurring, you want to assess if the reservoir is filling up. So I want to put this on to 10. So I can see here that the reservoir is starting to fill up, which shows that there is no leaks. So I also then want to perform a head tilt maneuver to open up the airways. You then want to insert an OPA or an MPA, so in this case I'm going to insert an OPA. So you want to measure this to your patient from their mouth to their mandible, and so you want to measure it and see if it's correct size and insert it at 180 degrees. Like so. So you want to twist and it should fit in like so. So you want to then fit the mask on the patient's head the correct way up, so that's the head in first, then the nose. So I'm going to do this like so. And since I am a single user, I'm going to be using the CE grip to ventilate the patient every 5 to 8 seconds. So every time I ventilate, I want to check for chest raises and gastric inflation. So there, when I ventilated, the chest rose, and that is what I'm checking for. For gastric inflation, you want to put pressure on the anterior and posterior cricoid ring, which is on the larynx, roughly located where the Adam's apple is, and this moves the trachea posteriorly and compresses the esophagus to prevent aspiration and gastric inflation. So generally, a second user would be doing this, and you also want to use the MOANS acronym to assess the effectiveness of the bag valve. For fracture management, I've got a patient here that has a suspected right tibial fracture. So before I start, I'm going to explain the procedure of splitting to the patient and also gain consent. So I'm going to expose the injury as well as the uninjured leg in order to compare the two. Like so. And I'll also gather history to determine the likelihood of the fracture and what led him to the circumstances that he's in. So I'm going to use the acronym plus discs to assess. So the first thing I'm going to ask about is pain. So what kind of pain he is in, and then I'm going to assess also the loss of function. So I'll try to get him to wiggle his toes and move his legs, and while he's doing this I'm going to be checking for any unnatural movement, any swelling, deformities or any irregularities. So any shortening would then suggest a femur break, and also I'm going to look at cryptus while I'm palpating, and that is the sound of bones creaking or crackling against each other. And also because he has a fracture, I'm going to be aware that the patient could also go into shock. So now I'm going to assess for cardiovascular and neurological integrity. So I'm going to feel for temperature at both the legs, hoping that they are the same, like so. And also by rubbing his foot or touching his toes, I'll be checking to feel if he can feel any sensations. I'll also be checking for his capillary refill to make sure there is no arterial bleeding or blockages. I'm going to also assess his pain on a scale from 0 to 10 to see how much pain he's in. This will help me determine what kind of pain relief to administer to the patient. The patient has indicated a pain level from 7 to 8, so I've decided to administer Antinox because it's used for moderate to severe pain. So it's a rapid onset between 2 to 5 minutes. It takes approximately 5 to 6 breaths to be effective and is also self-administered. So if I were to administer methoxyflurane, paracetamol or ibuprofen, then I would have to do a drug check with my colleague using the acronyms 5Rs and 4Cs. So a couple of contraindications I've got to be aware of is if the patient is unable to obey commands, if they have a suspected pneumothorax or bowel obstruction, if they've been scuba diving in the last 24 hours or have any known allergies. So because the patient is alert and aware, I've asked him if he has any of these conditions, which he doesn't. And this also shows that he's able to obey commands. So now I've got to also inform the patient that there are side effects such as euphoria, sedation, nausea, metallic taste, and also auditory disturbances. But I'm also going to let him know that this only happens in a few people and that most people are fine. So to assemble Antinox, you want to put the filter and a disposable mouthpiece on. Like so. And you also want to get rid of this after each patient. So you get the patient to bring it up towards their mouth and then take deep breaths in. I will do this and also then do another check of the pain scale to ensure that the pain relief has worked sufficiently before I start splinting. So the patient has indicated a pain level of 2, so I can now move forward and start splinting. So when applying a splint, you want to select the appropriate splint first. So for this, I'm going to use a box splint, which is made out of cardboard. So you can isolate the foot as well by cutting the seams, and this is also one that I prepared earlier. So I'll explain to the patient what I'm going to do, letting him know that I'm going to be putting his leg into a splint to immobilize the leg and protect the wound. So I'm going to ensure that I'm providing enough support and immobilizations. So I'm going to get a towel now and place it inside the box. So I'm also going to be wrapping above and below the fracture site with triangular bandages, so I've already placed them under the splint. So I'm going to then gently lift the leg up and slide the leg into the splint, making sure that it is in the box correctly. I'm also then going to tie above and below the fracture line with the triangular bandages. So, once splinting,
Carry on.
I'll just keep doing this because then I can fast forward. Okay. So once splinting is done, I will again check for cardiovascular and neurological integrity. So I'm going to be feeling for temperature in both legs and touching his feet and toes to see whether he feels sensation. I will also want to then check for capillary refill. When applying a cervical collar, you want to utilise the Nexus rule, which is the National Emergency X-ray Utilisation and Study rule. So for indications for applying a cervical collar is posterior midline cervical tenderness. So you find that by palpating, and they have no evidence of intoxication, they're alert, and their mental state is a 5 out of 5 on the verbal score. You also want to look at neurological deficits, so if there's any numbness in the fingers or toes or any other pain or distracting injuries. So for applying a collar, you need to explain the procedure to the patient, and you also want to gain consent. So once you've gained consent, you need a second person to help stabilize the head. So Nicole, if you could please hold the patient's head. Thank you. So to measure a C-collar, you want to measure from the clavicle to the chin with your hand, like so. And so this is about a 4, so you want to then measure this on the collar from the bottom blue line up. So once you've got the size that you want to lock it into place. So once it's adjusted to the right height, you want to then pre-bend the collar so it's a bit easier when it's going around the neck. So you want to get this on nice and tight. And it needs to be tight so that it mobilizes the neck. When approaching a scene, you want to assess for dangers, so your doctor ABCs. And so I can't see, smell or hear any danger, so I'm going to approach the patient. Hello sir. Hello sir, it's the ambulance. So I got no response, so I'm going to check his airway to see if there's anything obstructing. And looking through there, I can't see anything that could be obstructing his airway. So I am going to be looking and listening for 10 seconds to assess his breath. So I got nothing from that. So Nicole, would you be able to start CPR, please? While she's doing that, I'm going to radio for help as well as attach a defib. So AUT 1 to comms.
Comms receiving, go ahead.
We have an R49 requesting an R50, please.
Copy that.
I'm going to be working around you, Nicole.
Analyzing heart rhythm.
And stay clear.
Do not touch the patient. Paused. Start CPR.
So we start CPR, Nicole. So while she's doing that, I'm going to be putting an OPA in, as well as getting my bag valve mask ready and attached to running oxygen. So Nicole, when you get to 25, can you please count down to 30?
25, 26, 27, 28, 29, 30.
Be 2 breaths, looking for chest rises. Nicole, can you please continue? So during this time, I will be looking for anyone who's seen what happened to the patient, also to see if there's any family or friends around that can help with any contraindications, as well as continuing CPR.
25, 26, 27, 28, 29, 30.
Chest rise. Chest rise, please continue, Nicole. Also with CPR, you want to have 1/3 depth, as well as maintaining 100 compressions per minute with full recall, as well as stopping every 2 minutes.
26, 27, 28, 29, 30.
Chest rise. Chest rise.
One, 25, 26, 27, 28, 29, 30.
Chest rise. Chest rise.
Stop CPR.
So everyone please stay clear of the patient.
Analyzing heart rhythm. Stay clear of patient. Shock advised.
Everyone stay clear.
Deliver shock now. Press the orange button now. Shock delivered.
Everyone stay clear.
Pause.
Be swapping.
Start CPR.
When delivering oxygen to a patient, you need to always ask for consent prior to putting on the mask. So there are 3 ways of identifying an oxygen bottle. The first is the through port on the pillar valve for the regulator. The second is the label on the bottle, and the cylinder itself is white. So there's 5 different oxygen delivery devices that we use. The one is nasal prongs, and they deliver 28% oxygen and have a flow rate of 2 to 4 litres per minute. The second is the acute or Hudson mask. This administers 60% oxygen with a flow rate of 6 to 8 litres per minute. The third is the non-breathable high concentration mask, which delivers 90% oxygen at a flow rate of 10 litres per minute. Then you have the bag valve mask, and this delivers approximately 98 to 100% oxygen at a flow rate of 10 to 15 litres per minute. And then finally you have the nebulizer, which is used to administer liquid drugs and delivers 60% of oxygen at a flow rate of 6 to 8 litres per minute.